Welcome to our presentation about the short-term effectiveness of a personalized, stratified, blended care intervention in patients with non-specific low back pain. We would like to thank the World Confederation for Physical Therapy for giving us the opportunity to present our study results in the upcoming 8 minutes. As we all know, low back pain-related disability and the consequences of this low back pain are high, and clinical practice guidelines recommend a patient-centered approach in which patients with an increased likelihood of delayed recovery are identified at an early stage and treatment is stratified accordingly. And in addition to this stratified approach, the adherence of the patients is crucial for the effectiveness of care. And online applications such as apps can be effective means to stimulate this adherence between face-to-face sessions. And besides that, online applications can also help to stimulate the self-management of patients. So when we integrate the advantages of a smartphone application in face-to-face physiotherapy, so-called blended care, and use the knowledge of stratified care, we hypothesized that our intervention would positively influence the patient's self-management skills and adherence during his period of low back pain, which will be visible in an improvement of patient physical functioning on the short term when compared to face-to-face physiotherapy. And therefore, the aim of our study is to investigate the short-term 3 months effectiveness of e-exercise low back pain. To investigate this, we conducted a multi-center cluster randomized controlled trial in 58 physiotherapy practices in the Netherlands, and the practices were randomized at the level of the practice. Within those practices, a total of 122 physiotherapists were involved, and they recruited 208 patients with non-specific low back pain aged 18 years and older. Half of the patients received e-exercise, and as mentioned, e-exercise is a blended intervention in which e-coaching by means of an app is integrated within face-to-face care. And the content of e-exercise is based upon the recommendations of our clinical guidelines for non-specific low back pain. And within e-exercise, both the content of care and the number of face-to-face sessions are stratified using the StartBack screening tool. And e-exercise low back pain is compared to usual face-to-face physiotherapy, again according to the guideline. And it includes the same 3 elements as e-exercise low back pain, namely information, exercises, and recommendations regarding physical activity. And at 3 months follow-up, we looked at the effectiveness on physical functioning as measured by the ODI by means of a mixed model analysis. And thereafter, we considered several secondary outcomes, including pain intensity, fear avoidance belief, self-management ability, and self-reported adherence. And when we take a look at the results of our study, the baseline characteristics for the 2 interventions were comparable. At baseline, the e-exercise low back pain, however, consisted of more males and more patients with a duration of low back pain longer than 12 months, but no other differences were observed. And when looking at the risk of developing persistent low back pain, we see that the majority of patients were at low risk of developing persistent low back pain, and only a small group of patients had a high risk of developing persistent low back pain. And when we then look at our main results, our main analysis, several things stand out. At first, both e-exercise low back pain and face-to-face physiotherapy showed a clinical significant within-group improvement of 11 points on physical functioning. Besides that, on secondary outcomes, the e-exercise low back pain group also showed an improvement in average pain intensity and fear avoidance belief. For the face-to-face physiotherapy group, within-group improvements were only significant for average pain intensity. And since the improvements for both groups on physical functioning and pain intensity were more than 30%, they are also considered clinically relevant. Secondly, the between-group results showed no difference between the 2 interventions. The exercise group improved on average 2 points more in physical functioning than face-to-face physiotherapy, but this is not statistically significant or clinically relevant. And this would lead us to the conclusion that there is no difference on the short term between the 2 interventions. and this can be clarified in two ways. A first possible explanation is that we only measured at 3 months follow-up. And since it might be expected that e-exercise low back pain offers better and more adequate support to patients during the management of their low back pain, they might recover more quickly. And only measuring at 3 months might be too late to see this influence of our blended care intervention. Another plausible explanation is the high number of patients with a low risk of developing persistent low back pain. As we know from previous research, a stratified approach is not beneficial for low-risk patients because of their favorable prognosis, and this was more than 60% of our included study population. Finally, when we look at the secondary outcomes, the between-group differences were significant for fear avoidance belief and patient self-reported adherence. All other secondary outcomes showed no statistically significant difference. And since the risk of developing persistent low back pain proved to be an effect modifier, we also investigated the between-group differences per risk profile. And in patients with a low risk for developing persistent low back pain, no between-group differences were found on all outcomes. And for patients with a medium risk, only fear avoidance belief showed a significant between-group difference in favor of e-exercise. However, when looking at patients with a high risk, all outcomes showed a consistent improvement in favor of e-exercise, and for physical functioning, average pain intensity, and fear avoidance belief, this improvement was also statistically significant, indicating that e-exercise low back pain might be beneficial in this specific subgroup. However, it must be said that the number of patients in this analysis was very low. So based upon our study results, the take-home messages are the following. At first, e-exercise is not more effective, but also not less effective than face-to-face physiotherapy in patients with non-specific low back pain. Thereafter, e-exercise low back pain seems to be the preferential treatment strategy in patients with a high risk of developing persistent low back pain, although more research is needed. And finally, e-exercise low back pain could be an alternative treatment approach for patients with low back pain because of the significant and clinical meaningful within-group results, although this was not the primary purpose of our study. Thank you for your attention, and a special thank you for the contributors to this study and the Task Force for Applied Research who funded this study. I am looking forward to your possible questions.